This is Where We Live from Connecticut Public Radio. I'm Sujata Srinivasan in for Lucy Nalpathanchil. The Association of American Medical Colleges projects a shortage of up to 48,000 primary care physicians by 2034. Primary care comprises family medicine, general pediatric medicine, internal medicine, and geriatric care. This hour of Where We Live, we take a deep dive into why primary care is the barometer of the healthcare system and how the changing practice landscape is affecting both doctors and patients. Later in the hour, we'll hear from two new primary care doctors about their choice to pursue the field, and the head of the primary care internal medicine residency at Yale School of Medicine about what Yale's doing to get more graduates attracted to primary care. But now, we're joined by Timothy Hoff, Professor of Management and Health Policy at Northeastern University, also an Associate Fellow at the University of Oxford. Hoff is the author of Searching for the Family Doctor, Primary Care on the Brink, published this March. It's a pleasure to have you on the show, Timothy Hoff.
Thank you for having me. It's a pleasure to be here.
Congratulations. I believe it's your third book on primary care, Searching for the Family Doctor. Now, would you read aloud a passage from it for us?
Sure. This comes from the start of the book. There is a fight going on for the soul of not only American healthcare, but healthcare everywhere. Primary care is at the center of this struggle, the essence of which is the unresolved tension between two different goals. One goal is a fair, empathic, and highly relational care delivery system, built around primary care and trusting relationships between doctors and patients. Another goal is a more efficient, convenient, and highly transactional care delivery system, more impersonal and built on algorithms, healthcare corporations, and technology. The former needs family doctors to succeed. The latter probably does not, relying instead on business thinking, scale, cheaper labor, and technology. Why should we be interested in this struggle and who wins? As family doctors go, so may go other types of doctors, along with the notion of a healthcare delivery system with the physician-patient relationship and physician expertise at its core. The ideal of a comprehensive or generalist doctor who can manage our care and needs holistically could vanish. These types of doctors and the primary care medicine they practice are eminently important for all of us to lead longer, happier, and healthier lives. The kind of medicine family doctors dispense is focused on preventing disease, keeping individuals healthy, improving the health of communities, and taking care of health problems before they spiral into bigger problems. The best family doctor-patient relationships have high degrees of interpersonal trust, empathy, respect, and loyalty. These features have been shown over time to be vital to improving people's health. But it is not just the kind of medicine that counts. It is the human-to-human bonds that family doctors form with their patients which positively impact patient care. It is the notion of healthcare as a humane enterprise, typified not by decisions around what is most efficient and least costly, but rather around what is most caring and conducive to patient needs. And this is why the struggle is so important.
Thank you for that. Now, are you implying that the experience of a trustful relationship with a primary care physician who offers care with empathy is at loggerheads with an efficiency-driven, technology-driven system of care delivery?
Yes, I think it is. And I think, there's an inevitable tension in all walks of our lives between, doing things in a more relational way in terms of, services we access, where the interactions with people count, the human qualities count, and, more of the things we might do in our lives that really rely more on speed, efficiency, access, quick access, convenience. And so while it's not an impossibly difficult to solve necessarily tension, it sort of is a natural tension. It's hard for a doctor to have a good, deep relationship long-term with the patient if they're also responsible for, you know, sort of being on a treadmill and seeing lots of patients every day, seeing patients quickly, using technology to get between them and the patients. So yeah, it is a tension. It's not unresolvable necessarily, but it's there.
Would you say some of this plays out into physician burnout and the reason why we see this looming shortage in primary care physicians?
Absolutely. That's a great point. I also study things like burnout among doctors. And the research shows that, the causes of burnout for doctors, and in particular primary care doctors, relate to things like, patient care workloads that they can't control. How many patients do they have to see every day? Using the electronic health record or technology too much in their everyday work. Which then gets between them and their patients. At least they perceive that. And so a lot of this efficiency focused, quality documentation focused, transactional focus that increasingly primary care medicine is being pushed towards, certainly, if you look at all the research, is a big driver of physician burnout and what we also call moral distress. Doctors just sort of wondering if they're ever going to be able to meet the ideal of what they trained for.
What did your family doctor mean to you and to your community?
Where I grew up, we had a family doctor that we knew for a very long time, that my entire family went to. We had the same pediatrician that took care of, all of us. I was in a family with, 5 children total. So, my parents knew these doctors. My parents trusted these doctors. I saw firsthand growing up how important it was to have sort of a go-to group of physicians that also knew something about you, so that when you went in, they asked you about your family and your background and what you were doing in your life. And it just sort of made you trust them more.
In your book, you write about Dr. Richard Rutland. Tell me about him.
Yeah, so he was a doctor that, in doing the research for the book, I found when I was doing the historical research at the Center for History and Family Medicine, I found all these letters, thank you letters from patients, handwritten. And, this was a doctor who worked in a rural part of Alabama for many years in the 50s, 60s, and 70s. He was the Good Housekeeping Doctor of the Year one year. And, he really sort of aspired to the ideal of the true general practitioner, someone who could try and do it all. And, worked for his patients as an advocate, addressed health needs in the community, taught other doctors primary care, and then also pretty much was around 24/7, lived in the community he practiced in. And so, reading through these letters, which are threaded throughout the book, and hearing the personal stories of how this doctor helped some of these patients was really touching.
Here's one that particularly caught my attention. You mentioned Dr. Rutland was the Good Housekeeping Physician of the Year, and this letter references that. Dear Dr. Rutland, congratulations on your retirement. You really deserve some time off. One of my first and best memories of you is August 23rd, 1968, when you delivered my son because Dr. Breitling was out of town. Another memory I'm very grateful for is all the years you were my dear mother's doctor. She was so proud of you when you won the Good Housekeeping Award. She cut out the article and showed it to everyone who came to see her. You always made her feel better and lifted her spirits, even in the last days when nothing medically would help her. Karen L. And it really goes to show, the full spectrum of care. Now, that kind of relationship, in today's environment where the continued acquisition of physician practices by hospital groups in Connecticut and elsewhere, and, also the proliferation of urgent care centers, where there are alternatives to going to see your physician because, there's just no appointment available. How is all that changing the dynamics of this relationship?
Yeah, well, at a big picture level, it fragments the ability for the primary care doctor to have a holistic relationship with their patient. We go to urgent care centers because they're convenient. And look, there's problems with trying to get maybe into a primary care doctor's office. You can't get appointments when you want. They're overcrowded. And sort of I get all that. But the choices then we make to go to urgent care centers and not see our regular doctor, those have consequences for how well that doctor ends up knowing us, knowing what our health problems are, and really being able to have a continuous care relationship. So these more episodic places of care, while they've helped address access issues and timeliness and convenience issues for primary care, they've undermined in some ways the relational elements of the primary care doctor-patient relationship. And, in terms of the hospitals, and big health systems buying up more of the smaller primary care offices, I mean, the issue there is that makes the primary care doctor an employee of the larger system. And the relationship moving forward with the patient really becomes the relationship between the health system and the hospital and the patient, not necessarily with the primary care doctor and the patient. So that's the issue with sort of that consolidation that's going on.
Now, is there any way you think that in this practice landscape, technology can be an asset in delivering healthcare? With the acquisition of One Medical by Amazon, how do you see that playing out, and what good can come from it?
Yeah, absolutely. Look, the technology used in the right way in healthcare can actually potentially help, strengthen in some ways the doctor-patient relationship, particularly in primary care, right? We saw this during the pandemic, right? When people could not get in to see their doctors face to face, they were able to, go on Zoom or some other platform and have telemedicine visits with their doctor. And so that so technology in the best way can enable busy primary care doctors to maintain relationships with patients they already know, because they can offer speed, they can offer convenience, because maybe the doctor just can't get every patient in the door to see them on a regular basis. And so that really is the promise of technology, in one big way for primary care and relational care. It's thought of as really technology complementing what the primary care or family doctor does for their patients, not replacing it. And I think that's the big thing we need to keep in mind.
Right. And how do you see Amazon changing the way primary care is delivered?
Well, these big technology companies and retail-oriented companies, I wrote in an earlier book. I mean, we're living in the consumerization of healthcare. It's a sector that's no more immune from the consumerization movement as any other sector. And what that means is these big companies are going to come in and they're going to try and create efficiencies and scale to deliver services in a lower cost way, which isn't necessarily bad. And so I think a company like Amazon, getting involved in primary care could yield some real positives, particularly in terms of, companies like that knowing how to do things better in terms of reaching customers that maybe the healthcare system simply, does not know how to do as well. And so that I think is the promise for that companies like that are going to want to get involved in primary care. But as we see with a lot of these big companies, they get involved and they realize it's much more difficult than they thought it would be.
Now, talking about barriers to entry for people in this field, you write that poor reimbursement rate for primary care physicians compared to specialty care is one of the reasons why more people don't want to get into primary care.
Yeah, it's there's the macro issues that revolve around the system, that prevent medical students and young doctors from wanting to pursue primary care, jobs. And those those system issues are things like inadequate reimbursement for primary care. I mean, primary care is undervalued and underpaid for in this country. It's not in other countries that build their systems around primary care, but for us it is, because we're built around specialty care. So, you take a set of services that aren't well paid for. They're going to necessarily then be undervalued. That means the doctors doing that work are going to be paid less, which also is going to convince more maybe younger medical students, hey, I'm doing all this to become a doctor, and I'm going to make this much less than somebody else, and I'm supposed to be doing a very important job. And then the other issue is it's a really hard job to do well. Being a full-fledged primary care physician where you're taking care of, a panel of 2,000 or 2,500 patients longitudinally, that's a really hard job. Even with technology and even with sort of the modern ways of innovations that we can bring into play here. And so, a lot of young doctors and medical students, they see how tough the job is to do right. And it can be scary. So I think all those sort of things combined make it, a field where, physicians, young physicians and medical students just simply don't flock to as much as they do to other specialties. And that's a real problem.
Now, the Affordable Care Act increased Medicaid reimbursement rates for primary care services in 2013 and 14. And in 2020, Medicare reimbursement rates increased for primary care for the first time since the 1990s. Now, do we have any evidence that these policy measures worked in attracting more people to the field?
Not from what I know. I mean, there might be research out there, but the numbers each year, for example, of students choosing family medicine, for example, the numbers have not gotten any better. So it remains an ongoing problem. And I think as much as the reimbursement now, the issue is really just the lifestyle and how challenging the job looks to younger medical students. And so that also combines with, the payment issue to really create a lot of disincentives for people to choose the field.
Tim, talking about medical students, I mean, what can primary care residency programs at medical schools do to attract more students into this field?
Reinvent how they look at primary care, reinvent how they present primary care and family medicine to young students. Most medical schools, traditionally have not cared very much about turning their students into primary care doctors or family doctors. And if that doesn't change, then this problem will continue. So, you need real leadership in these medical schools. You need new models of training family young medical students, like Kaiser Permanente, big hospital systems, creating their own medical schools and emphasizing primary care in the training of medical students so that they can turn out more of these doctors. But there really needs to be a sea change in how medical schools perceive the whole practice and field of primary care and communicate that, get young students excited about wanting to choose this field rather than sort of conveying the notion of, hey, be a specialist, don't go into this field.
Timothy Hoff, Professor of Management and Health Policy at Northeastern University and author of Searching for the Family Doctor, Primary Care on the Brink. Tim, thank you for your time.
Thank you so much for having me.
Coming up next, we hear how the Yale School of Medicine is attracting medical students to primary care. From Connecticut Public Radio, this is Where We Live. I'm Sujata Srinivasan in for Lucy Nalpathanchil. We'll be back after this break. This is Where We Live from Connecticut Public Radio. I'm Sujata Srinivasan in for Lucy Nalpathanchil. Today we are talking about the shortage of primary care providers. Enrollments at primary care residency programs at medical schools in Connecticut have at best held steady. At UConn, between 40 to 50% of graduates from the School of Medicine typically enter primary care residencies. In 2022, that number dropped to 26%. UConn offers loans at 1% interest rate as long as graduating doctors practice in family medicine. internal medicine, pediatrics, or geriatrics in Connecticut. The Quinnipiac School of Medicine had 39 students in both 2020 and 2021 who chose to specialize in primary care. That number rose by 1 student this year. We're joined by Dr. John Moriarty, Program Director of the Primary Care Internal Medicine Residency at Yale School of Medicine. Dr. Moriarty, it's a pleasure to have you on the show.
Thank you. It's a pleasure to be here today.
I understand that enrollments have held steady at the Yale program, about 18 primary care residents a year, but the numbers haven't really gone up. Why aren't students excited about primary care?
Yeah, Sujata, I think it's a very interesting question. One of the things that we have learned about is that oftentimes students will be taking a look at current models of primary care, a lot of which are in a fee-for-service model where primary care providers need to see, upwards of 4 patients over the course of an hour for 8 to 10 half days a week, and they see that model and have concerns about, are they going to be able to, number one, develop the longitudinal relationships and depth of relationships they would like with their patients, and is it going to lead to burnout given the churn of seeing multiple patients over the course of a day?
Right, and you bring up the longitudinal relationship component of primary care, but also in terms of patient outcomes. Is there a difference between outcomes, from a value-based model, which is more population-based, versus a fee-for-service model, which is, based on the volume of patients seen and reimbursed?
Yeah, I think there are a lot of things that are attractive about value-based care. Certainly one of them being the focus on a population health of patients, not just simply the patient that's in front of you in the clinic, but thinking more broadly about your entire patient population, using data to really guide your care, and using data as well to guide the type of care that you're providing, understanding that care might not just be a single in-person visit. It might be a telehealth visit. It might be a group visit. It might be a visit that involves a health coach focusing on nutrition or health prevention or other aspects of care.
Right. So that would deal with populations who might be at risk for diabetes, the pre-diabetes, the people who are building up, to a cardiac risk, and so forth.
Correct.
Now, given the shortage, according to the Association of American Medical Colleges, the AAMC, prior to the pandemic in 2019, 35% of survey respondents said they or someone they knew had trouble finding a doctor in the past year or so. That's a 10-point increase from when the question was asked in 2015. Now, what's Yale doing to help attract more medical graduates to the primary care residency program?
Yeah, so one of the things that we're focusing on is looking at the experience of the graduates within the residency training program. It's interesting, if you look at data from primary care internal medicine residencies, only about slightly over half, about 57% of graduates of primary care residency training programs actually go into primary care. If you look at categorical internal medicine programs, their numbers are about 20%. So really part of the goal should be focusing on enhancing the residency education so that more residents are interested in careers in primary care through the exposures they have in residency. Some of the things that we've been doing in our residency training program to really try to enhance the experience of residents and interest and engagement in primary care have included exposing them to other care practices besides the residency continuity clinic. The residency continuity clinic is often in internal medicine residencies, a hospital-based clinic, often cares for a biopsychosocial complex patient care population, often with not a lot of resources. So in our residency training program, we have allowed residents time to go out to see other practices within the state, actually even within the country, and also expose them as much as we can to alternative models of primary care, like value-based models. And I think this has excited a lot of our residents to really kind of think about what futures in primary care look like, and then also educate them on how to be leaders and agents of change so that they can really advocate for change in the healthcare system that will lead to better outcomes and better experiences for residents in primary care.
Would you elaborate a little bit more about the value-based model and what exactly do your residents get to experience when they are exposed to working at organizations that provide this kind of service to patients?
So back in 2016, one of our core faculty members, Dr. Bradley Richards, started to develop a curriculum looking kind of at healthcare financing and looking at models of primary care. And he started an elective experience for our residents, a 2-week elective, which we called the Innovations Elective, where during that 2-week period, residents would have some content and classwork looking at healthcare financing and understanding models of care, and then get to meet with leaders of novel, innovative practices such as Iora Health, such as CareMore, such as Oak Street, and even get to visit these sites and understand what these new models of care look like and how they organize care differently from a fee-for-service model, incorporated aspects of care like health coaches, more effectively using advanced practice providers, and thinking about how to use embedded mental health as well in a primary care practice.
I'd love to bring in Dr. Eva Zimmerman into the conversation now. She'll start working as a primary care physician in October at the Internal Medicine Associates of Westport, right here in Connecticut. And she was one of your students at the Yale residency program. So, Dr. Zimmerman, what is your response to the way the primary care practice landscape is changing? I mean, what are you passionate about, but also what are your concerns?
Yeah, I was fortunate enough to be a member of a resident of the Yale primary care program and have the opportunity to be kind of exposed in the forefront of this changing landscape of primary care. So I feel very fortunate and lucky, and that definitely determined kind of where I ended up in my job at Internal Medicine Associates of Westport. I was also fortunate enough to have a family member, my father, be a primary care doctor back in Buffalo. So I got to see kind of the inner workings of an autonomous physician and what that was like in private practice, and also kind of see over the last 10 or so years the relative corporatization of medicine and smaller practices being bought up by larger healthcare organizations and physicians losing a lot of autonomy. So kind of with my training at Yale, as well as my background with my dad's small private practice, I had a sense of what I wanted to do in primary care and what I wanted it to look like. I definitely wanted a job that could incorporate the key components of primary care, longitudinal relationships with patients, coordination of care, also quarterbacking care and, communicating with consultants, but also not be in one of these situations where I would feel like I was churning out patients, not being able to spend enough time with my patients, because that's something that I know is key to better healthcare outcomes, better patient satisfaction, and just overall also doctor satisfaction at the end of the day.
Now, with the number of hospital acquisitions we've had in Connecticut and across the country of physician-owned practices, how easy or difficult was it for you to find the right fit in this job?
We did get a lot of exposure at the Yale primary care program to different models outside of just the resident continuity clinic, which was very helpful in tailoring what I wanted to do in my own practice. So having those opportunities kind of helped me hone, did I want a small practice or a large practice? Did I want to have a practice that incorporated advanced practitioners and mental health? Or did I want kind of more of a private practice where it's a couple of doctors and you're all kind of working together to to solve issues. And I also, being a graduate and with the low number of primary care doctors in the area, I was in high demand because I knew I wanted to go into primary care. I ended up working with a recruiter who I told about the characteristics of the practice that I would like to work in. And the number of options that fit kind of my criteria for where I wanted to work were actually very limited. So while it was easy to find a job, the number of jobs that fit kind of the number or the bill were few and far between. So I feel very fortunate to have found the job that I did.
Now, you're passionate, Dr. Zimmerman, about providing longitudinal care, but how does this fit in the urgent care model? We've seen a proliferation of urgent care centers across Connecticut and the country, and PCPs, as we all know, can be booked well into a month out. So urgent care is becoming a substitute for some patients. So how does this play out?
I think urgent care has helped to offload doctors when there's an urgent complaint that may not necessarily warrant an emergency room visit and maybe off hours to when the doctor is typically practicing. So I think there is a very specific role for urgent care, but high utilization of urgent care is in substitute for primary care offices is definitely something that is probably detrimental all around, not only to the doctor-patient relationship, but also to healthcare outcomes in general.
Now, if you don't mind talking about your student debt, medical school is not inexpensive, and according to the AAMC, the average medical school debt was $200,000, and that's not including the undergraduate debt. So while making the decision to get into primary care, and you mentioned, you come with so much energy, Dr. Zimmerman, you bring so much passion into this field. But in terms of money, was that a factor in your decision?
Yeah, I think student debt is definitely something that needs to be talked about, especially amongst those who work so hard to get where they want to be. And usually our journeys are upwards of 10 plus years. I was fortunate that student debt didn't play into my ultimate decision, but is certainly something that is coming up frequently for me and my colleagues in making decisions in what area to pursue. There are some programs that offer repayment of loans, and a lot of jobs, when you're signing on, offer that as a perk or a bonus, kind of as an incentive for you to work at that practice. Even the smaller primary care practices are. I knew I wanted to do primary care from a very young age of 11, and I kind of stuck with that and didn't really let the financial payoff or burden determine my decision to do that. But I can't say the same for a lot of my colleagues who may have chosen. That's definitely a thought in the back of your mind when you're deciding kind of ultimately what I'm going to go into is, over $300,000 of loans sometimes and having to ultimately pay that off at some point.
What is the landscape going to look like? We have all of these aspects, the retirement of physicians, the projected shortage, the debt, medical school debt, the relatively low pay of primary care compared to other disciplines and so forth. So how do you see this playing out, Dr. Moriarty? Going back to the AAMC data, about 48,000 primary care physicians expected shortage by 2034. And do you expect nurse practitioners, physician assistants, filling some of the shortfall? What's going to play out?
Yeah, I think it's interesting. So something clearly kind of needs to change in how our systems broadly defined invest in primary care, and I think there are multiple ways to think about how to fill that gap of that 48,000. And I think it's going to require multiple different approaches. Certainly one of those approaches is increase the number of primary care residency training slots, which has happened over time, both in internal medicine and in family practice. And, you probably would have to increase by about the number of slots by about 21% to really get to this offload. And that is certainly something that programs are starting to invest in. You talk about advanced practice nurse practitioners, physician associates are also ways that can help fill the gap in primary care. I think one of the investments in really highly functioning primary care healthcare systems, involves physicians, advanced practice nurses, and physicians' assistants really kind of working together in a well-coordinated interprofessional team to care for populations of patients. And that really is, I think, what the future of primary care should look like. And then I think the larger investment needs to be in the investment in the primary care health system. We've already mentioned sort of consolidation of healthcare systems and hospital systems, buying up practices. And it would be nice to really see those healthcare systems start to invest in their models of care, start to move towards more value-based care options, which look at really quality of outcomes for populations of patients, that really start to drive change in the setting of doing things like incorporating embedded mental health care, incorporating true interprofessional teams, and really also learning how our larger healthcare systems can really engage not only with patients, but also engage with their communities to really advocate for better health of their communities in a primary care landscape. And again, the hope is, you mentioned the burnout challenge and the increasing retirement age of physicians. And if we don't, redesign our models of care so that they are models of care that students are excited about entering into, the experience early in their career trajectory, positive models of primary care, and then incentivize it so that either you can repay some of that debt or even maybe pay primary care a little more for the value that it can provide to individual patients and communities.
Dr. John Moriarty, Program Director of the Primary Care Internal Medicine Residency at Yale School of Medicine. Thank you for your time.
Thank you.
And thanks to Dr. Zimmerman. She's beginning her career in primary care medicine at the Internal Medicine Associates of Westport. Good luck, Dr. Zimmerman.
Thank you so much.
Coming up, we hear from a primary care physician who graduated from the School of Medicine at Quinnipiac University in May, a recipient of the school's fellowship to study primary care. I'm Sujata Srinivasan in for Lucy Nalpathanshire. This is Where We Live. We'll be back after this break. This is Where We Live from Connecticut Public Radio. I'm Sujata Srinivasan in for Lucy Nalpathanshire. Today we are talking about the shortage of primary care doctors. The Association of American Medical Colleges projects a shortage of up to 48,000 primary care physicians by 2034. Joining us now is Dr. Sheila Ekbali. She graduated from the School of Medicine at Quinnipiac University in May, receiving the Primary Care Fellowship. Ekbali is currently pursuing a family medicine residency at Greater Lawrence Family Health Center in Massachusetts. Welcome to the show, Dr. Ekbali.
Thank you so much for having me.
It's a pleasure to have you here. What led you to medicine and to primary care?
Thank you for asking that question. I have for a long time been really interested in medicine and healing, but specifically what led me to primary care was my experience as a teacher. So before medicine, I was a teacher for 12 years, teaching science at the high school level. And I worked with a lot of kids who had history of trauma and a lot of life challenges that really made me realize not only the social determinants that affect people's education, but also their health. And one of the other things that happened as a result of this experience working with kids with a history of trauma was that I was working with the same kids up to 3 years in a row. And as a result of it, I was able to really build strong relationships. And sometimes I noticed it would take an entire year to build trust and have the kids be willing to listen to me and take my advice. And trust themselves and build confidence and so forth. And having that long-term relationship really made a difference in being able to help them thrive, both academically, but also, teaching them about nutrition and exercise and things like that. So also in terms of their health.
Now, are you confident that you'd be able to spend time with your patients, given, the heart of this is the need to build a longitudinal relationship, and given the changing practice landscape?
I think that one of the things I did before I applied to medical school, I spoke to my own primary care physician, and I asked the same question. I said, "Do you feel like you can spend enough time with your patients?" And and I think what she said to me was that I do what I need to do, and it works out. And essentially, we have a system that doesn't always work with us. It doesn't always set up enough time for us to see patients, but we also have the flexibility to push back. This is definitely a challenge that I think healthcare systems face, and both in terms of the amount of time we have with patients, to be able to push back to the system is one strategy. And another is to be in places that really value that continuity. So where I'm at right now, it's a federally qualified healthcare center. And one of the strengths of these FQHCs is that we have a holistic approach to healthcare. We provide a lot of different services, including social services and behavioral services. And we are really able to follow our patients for a long time. And there are actually benefits in the outcomes, and patients do better than in other settings. So I think that it really is a matter of seeing these types of systems work, and then expanding it into other places and other spaces.
And you received a fellowship from Quinnipiac Medical School to do a primary care program. I'm assuming that you don't have medical school debt, but if you did, would you have chosen a higher paying, different medical field perhaps?
Oh, I wouldn't have. I have a little bit of debt, but not very much. And I'm very grateful for this incredible opportunity to have my tuition paid for. But I had decided to go into primary care to family medicine prior to receiving this fellowship. And for me, coming from teaching, I feel that making $200,000, if you're making that much, and you're not making $500,000, that's still a lot of money. So I don't really feel that the salary is really something that would have changed my mind. And it's not really something that I have heard so much from my peers either.
And given that you practice right now at a federally qualified health center in the family medicine area, that does not require malpractice insurance should you want to practice there in the future.
That's correct. Yeah, I actually just learned that last week, which was super exciting, because I'm interested in full spectrum family medicine, which includes adult medicine, pediatrics, and providing care for pregnant patients, obstetrics. And sometimes that can be quite a bit more malpractice insurance. But if you're working through FQHC, the federal government really provides that protection.
I understand that you have other experiences that made you gravitate towards primary care, including your own health challenges. Could you talk about some of the experiences leading to this field?
Yeah, so I think that part of my own experience that made me want to go to primary care was that I had a lot of different symptoms and had a really hard time getting a diagnosis. It took me about 20 years to get a diagnosis. And actually, I sort of diagnosed myself first and then asked for the proper assessments that led to the actual official diagnosis. And throughout the whole process, I realized I was going to a lot of specialists, and everybody was seeing just a piece of the problem and not really putting it together. And what I really wanted was somebody who would put all the pieces together and solve the problem. And I really feel that primary care is a space where you can solve really complex problems. You can make massive changes in people's lives by being able to identify sometimes rare and sometimes just difficult to diagnose and complex health issues that might present in many different ways. And I feel that I'm going to have tons of opportunities to do that.
I'm sorry you had to go through what you did. I understand that you are also a dancer. Tell me more. Would you have the time for dance in your medical career?
I have danced for so long, and I didn't really dance very much at all during medical school, partly because I was sort of away from my base of where I do dance. Now that I'm sort of back in my space and my community, people sometimes go to the gym as a way to not just exercise and be healthy, but also sort of for mental well-being. For me, dance is that.
Right, and the creativity in dance to experiment. Perhaps there are parallels in medicine too, that you bring that creativity in the diagnostic process, that there's an art and science to primary care.
Yeah. Yeah, for sure. And I think that, I do Iranian dance, and part of what I have done is I traveled throughout Iran. I've done several trips where I go to rural areas and I gather dance and music and try to understand the cultural background behind the dances. And in doing so, I also saw a lot of health issues that were sort of prominent, and lack of access to healthcare. And one of the things I realized is how much wellness can come through dance, and how these two can be so related. And again, like you said, there's that sort of creativity and thinking about so many different things at the same time, which is a skill that comes from choreography and other things that I've done for many years, that transfers right into medicine.
In terms of medical school preparation, what was effective for you? I mean, did Quinnipiac Medical School expose you to the kind of practices that you wanted to get into, where you could build a long-term relationship with patients versus that fee-based model where you see a set number of patients within a set amount of time for reimbursement purposes?
Where I'm at right now, we do have value-based care because we're one of the pilot sites. But I did work with a family physician in Hamden who had a lot of patients for many, many years. And certainly seeing him work with the same people over so many years and know their stories and know their challenges was very inspiring. And to see how he was able to help them more just because he had those relationships was definitely something that left an impression on me, and I wanted to have that experience.
Now, as a teacher, you said you were excited working with children that came in from backgrounds, undergone trauma. I mean, did you work with them long enough to see a change in their outcomes? And how do you think that would play out in your own career as a doctor going forward? What's the big picture there?
Yeah, I think sometimes we don't realize some of the influences that we have when we do have long-term relationships with people. I was able to work with some of my students for up to 3 years. And, in that time, I got to know them really well. And even now, even though years have passed, I still get text messages and Facebook messages and emails letting me know how my students are doing and how they're progressing. And, everyone has their challenges, but I feel that having had some of those relationships certainly allowed some of my students to pick paths that brought their best selves forward and helped them flourish and be successful. There's not always a success story, but I think that we can make a difference without, we might not know that all the difference that we make. And I think medicine is the same way. Sometimes we say something, or we just, nod and acknowledge somebody's pain and suffering, and we might not even be able to fix it, but that being in that space with them and being able to generate a safe space for them sometimes can be part of their healing process.
Dr. Sheila Eghbali received a fellowship to do a primary care program at Quinnipiac University. She's now pursuing a family medicine residency at a federally qualified health center in Massachusetts. Dr. Eghbali, wishing you a long and fulfilling career.
Thank you so much for having me. Have a wonderful day.
I'm Sujata Srinivasan in for Lucy Nalpathanchil. Talk show intern Meera Raju helped me produce today's show. Special thanks to Katie Talarski. Thanks for listening, and be well.